Hi everyone, thanks for joining me today. My name is Grace Meehan and I'm a clinical pharmacist and I'm a certified menopause practitioner with the North American Menopause Society. And I want to speak today about bones and osteoporosis and importantly preventing osteoporotic fracture. This is a really important topic. It's not considered really a sexy topic in terms of menopause because it's not always on our radar. When we think of menopause, we're thinking about hot flashes, night sweats, the usual fare. And, our bones are pretty quiet. We're not thinking about them at all until all of a sudden we have an osteoporotic fracture, and then we're so surprised at what's happened to us. A few stats to start out with. Osteoporosis it's really important. It is the number one cause of morbidity, meaning disease, in postmenopausal women over the age of 65. Once you have a hip fracture, your risk of mortality in that first year post-fracture is increased by 25%. Once you've had a hip fracture, you're 25% more likely to require long-term care. Your quality of life, your independence decreases, increased risk of depression during this time. And the financial burden on the healthcare system is really significant. So this is, it's not always on our radar, but I want it to be on our radar because I think, certainly pre-menopause, but especially around the menopause years, can be a really good time to start thinking about your bones if you haven't already and try to prevent the fracture. So a little background as well, bones are amazing. They are always regenerating, which means that they're being formed by special cells in our body called osteoblasts. And then special cells in our body called osteoclasts are breaking down the tired bone. And there's this wonderful balance that goes on to give us good bone. And for women, estrogen plays a really big role in that balance, which is why around menopause, osteoporosis and preventing osteoporosis can become a big deal. Do you know that 2 to 3 years before your last menstrual period, bone loss begins to accelerate, and then 3 to 4 years after that last menstrual period, the accelerated bone loss starts to slow down, and then you just get a sort of a gradual progression of bone loss until you can possibly, unfortunately, end up with osteoporosis. So I can say, if you are in perimenopause or, sort of getting close to that last menstrual period and you're having some hot flashes and, sort of those symptoms of menopause are rearing their ugly head, that might be a time for you to think about hormone replacement therapy as a possibility to address the menopausal symptoms that you're experiencing, but also to decrease that accelerated bone loss that might be happening, especially if you have risk factors for osteoporosis, which I'm going to go through in a second. Okay, so talk to your clinician, talk to your doctor. Could hormone replacement therapy be a good thing for you? We can answer those questions for you. So what are the risk factors? Okay, risk factors for osteoporosis are increased age, nothing we can do very much about, genetics. So if you have a mom who has broken a hip like I did, then your risk of osteoporosis is higher. Low vitamin D status. So if you are low in vitamin D, and the only way to really know if you're low in vitamin D is to measure, which is something that we routinely do at NutriChem Pharmacy for bone health, but for all the other wonderful things that vitamin D does in the body. But low vitamin D status is significantly associated with it. Low estrogen is a risk factor. Malabsorption issues. So if you have celiac or gluten sensitivity, you're less apt to be able to absorb the nutrients that are important for bone. Increased caffeine intake, excessive alcohol intake, smoking, a bad diet that's full of sugar, starch, processed foods. That's all bad for your bones as well. If you're frail, So as we age, we often lose muscle as we get older. So if you are frail, if you are a thin woman with a low body mass index, those are risk factors as well. Certain medications, and certain medications, like if you're on an acid reducing medication, for heartburn, if you've been on that for longer than potentially you should be, then you're not going to be able to absorb calcium, magnesium, and other nutrients which can make you feel well. So that can be problematic. And at NutriChem, we're always looking at that acid-reducing class of medications to see if people really still need it. Anti-seizure medications can increase risk. Corticosteroids, which are used for inflammatory diseases, that will increase your risk as well. So you can speak to your pharmacist to see if you might be on a class of medications that's going to increase your risk of osteoporosis. If you're not exercising, exercise is absolutely so important in order to keep our bones healthy. We are meant to move. I'll say it many times, we're meant to move for all the other things exercise is good for, but also for our bones. Now, how do we diagnose osteoporosis? So if you're unlucky enough to have not been able to prevent it, how is it diagnosed? By something called a bone mineral density test. And you'll be offered a bone mineral density test at the age of 65 if you're a woman. And if you don't know, though, that you have risk factors for osteoporosis, you can ask for that bone mineral density test earlier, which can be a great idea so that you can catch it before you actually get to the point of osteoporosis. All right, so let's get to the medications. So say, you have been diagnosed. You weren't able to prevent osteoporosis, but now you've been diagnosed with osteoporosis, and you come to the pharmacy and you say, I have been diagnosed with osteoporosis and I have been prescribed this medication and I don't want to take it. And I hear that question a lot. The question is going to be, I don't want to take it. What else can I do? Unfortunately, medications that are prescribed for osteoporosis are often not taken. The adherence, the compliance with these medications is really, really poor. And I think that's just because, osteoporosis, until you have a fracture, we don't even think about it. It's not painful. We just want to go about our lives and not have this medication on board. But got to emphasize the goal is to prevent fractures. We know what fractures can do for quality of life and for our overall health, our morbidity, our mortality. So we want to prevent fractures, okay? So how I answer the question of, what should I do for osteoporosis or should I take for osteoporosis? There's many medications now that can be prescribed. So treatment is individualized. So it really depends on, your risk. It depends on your bone mineral density score, how severe it was. It also depends on whether you've had a previous fracture or not. If you've already had one osteoporotic fracture, then your risk of another is significant. So that can affect the choice of medication that you're going to take. Okay. So what's available? So if you're at very high risk of a fracture, if your bone mineral density test, called your T-score, is quite significant, if you have risk factors, you are going to be prescribed a medication class called anabolics. This is a class of medication given by injection that helps your body to build bone. And usually patients will be on this for several years and then switched off to another class of medication. Okay? If you're at moderate risk, moderate to high risk, then there's other options for you as well. And one can be hormone replacement therapy. Hormone replacement therapy, we're talking about good bioidentical estrogen, good bioidentical progesterone. These are options for many women. Estrogen is going to stop the osteoclasts from breaking down bone. And there's data to show that micronized progesterone helps the osteoblasts to build bone. So, Estrogen can also help with the other symptoms of menopause you're experiencing as well, like hot flashes, etc. So this can be an option for you. And we used to think that hormone replacement could only be used for 5 years or 10 years. But now we know that there's no data to support an absolute stop date. So, and I've addressed this in a previous video, that again, how long you can be on hormones can be individualized. There's no stop date. So, depending on what you and your practitioner want, you can continue it for longer. Once you do stop hormones, if you've taken them and if you've decided you want to stop, it's important to note that bone loss will start after you've stopped taking them, and you will have some accelerated bone loss right after stopping. So there should be a plan in place to address your bones again. Another class of medication, and this is the class that we get the most questions about, is called bisphosphonates. Bisphosphonates is a group of oral medications that women will take to help to stop bone loss. It's oral medication, very effective. It's like 40 to 70% decreased vertebral fractures when you're on bisphosphonates, and they prevent about half that in hip fractures. So they're very, very effective. Taken either once a week or once a month, depending on what your doctor prescribes. Now, what's the controversy? The controversy is a small risk of 2 side effects. The first being osteonecrosis of the jaw. Osteonecrosis of the jaw, very, very rare with the bisphosphonate group. It would usually occur in patients who are getting treated with intravenous bisphosphonates, and that would be cancer patients. And it would only really happen in patients who are getting dental implants or extractions. So it's very rare. Now we have to weigh the risk-benefit. The risk of osteonecrosis of the jaw is very, very small, but the benefit of that the bisphosphonate is quite good in preventing fractures. Remember, our goal is to prevent fractures in patients. The other rare side effect is called atypical femoral fracture. Now, the femur is the large bone of the thigh. So this is a really rare side effect. It's a fracture of the shaft of the femur. And the stats show that 11 out of 100,000 patients per year would experience this side effect. And it is treatable. And again, we've got to look at the risk-benefit. The risk of atypical femoral fracture is very, very small, but the benefit in preventing fracture is quite good. So, got to look at that. The bisphosphonate group, they have long action in the body in preventing bone. So you can typically be on it for 3 to 5 years and then take a drug holiday and be off it for 3 to 5 years, depending on which one was prescribed for you. So you could just be on it for 3 to 5 years, off it for 3 to 5 years. If you're considered high risk of a fracture, it may not do that drug holiday in you, or maybe you'll have the drug holiday, but then be prescribed a different class of medication. So as I've said, it's very, very individualized which way to go, but there's options. There's another medication on the market called Prolia, which is a twice yearly injection. Prolia has been shown to decrease fractures by 68% in the vertebrae and 40% in the hip. So very effective, very well tolerated. We've got data up to 8 years that show very well tolerated with no risk of atypical femoral fracture. So that's another one that can be used. So long and the short of it, it's individualized. If you have questions about the therapies prescribed, talk to your doctor, talk to your pharmacist, your clinician, because we can choose the best medication, one that you'll be happy to take, and then also help you with lifestyle, with supplementation, etc., along those lines. Okay? But remember, the goal is to prevent fracture, because fracture can be quite a traumatic change in your life. We also want to look at, remember I talked about muscle wasting. As we get older, we lose muscle. When we lose muscle mass, we are going to be more risk of fracture. So we want to increase or maintain our muscle by doing weight-bearing exercise, and we want to keep our balance. As we get older, we seem to lose balance. So we want to practice balance exercises as well. Like, for example, brush your teeth standing on one foot. Do that one night. Do the other foot the other night. Do yoga. Anything that's going to help you to keep your balance so that you don't fall will be really important. Okay? Now, the last section, I want to talk about dairy and the role of dairy in preventing fractures. As we've always been told that, we need to have dairy products in order to keep our bones really strong. But where was the evidence for that? Because interestingly enough, countries that have higher dairy consumption have higher risks of fractures. So the New England Journal of Medicine earlier this year, they looked at the role of dairy in preventing fractures. So they looked at people who had, and this was a meta-analysis, so large study. They looked at people who had low dairy consumption, like 1.5 servings of dairy per week, versus patients who had really high dairy consumption, like 30 servings of milk or dairy equivalents per week. And what they found was there was no benefit of having high dairy consumption in terms of fractures. The conclusion was that there was no overall evidence to support high dairy consumption in order to prevent fractures. So, that's interesting. It's different than what we thought. At NutriChem, we often recommend to patients that they stop using dairy products, like they eliminate for about a month or so, because a lot of people don't tolerate dairy very well in terms of gut health or in terms of increasing joint pain. So we try to get them to eliminate dairy to see if dairy is bothering them, but we often get the question, well, if I eliminate dairy, how am I going to keep my bones strong? So this has kind of looked at that. You don't necessarily need dairy products in order to keep your bones strong. What about calcium? Well, the New England Journal of Medicine looked at this as well. And they looked at patients who were taking calcium-only supplements as opposed to patients who were using placebo. And they found that there was no decreased risk of fractures in the patients taking calcium. So I think what we can glean from this is that, calcium is great if we get it from our diet, from our green leafy vegetables, our broccoli, our kale. Getting it from, eating fish with bone in. But the other things that are really important for bone are our lifestyle. We need to, decrease our caffeine, potentially, our alcohol, smoking. We need to make sure we have adequate vitamin D. Magnesium is especially important. Magnesium helps vitamin D to work well. And experts are now saying they really think that vitamin D is more important than even calcium that we're taking. Okay? So there's a lot that happens with bone. Other factors can be, vitamin K2. That's important for bone. Weight-bearing exercise, staying active, very, very important. So we don't have to think, I have to have all of this milk. I have to take 1,000 milligrams of calcium per day. This may not be the way to go. And in fact, high milk consumption has been linked to prostate cancer and to breast cancer and to endometrial cancer. So I think that the bottom line in all of this is let's prevent bone loss. Let's have it on our radar. Let's think about it. Let's be active. Let's optimize our vitamin D. Let's try to eat a good, nutritious diet, not necessarily the North American diet, but a diet that has a lot of vegetables in it and lean protein. Stop smoking. And let's talk to our practitioner about what the best choices would be for us for a supplement if we need it, and for treatment if we get to the point that we do get diagnosed with osteoporosis. So always happy to answer questions from patients. So if you have questions, let us know. Speak to a clinician or practitioner at NutriChem, and keep moving. Stay active. Just keep moving. Okay, and take care and have a really healthy, happy day. Bye-bye.